Hello, I'm Karen Parry. I'm the director of the East Brunswick Public Library, and I'd like to welcome you all to this very wonderful, exciting program tonight called Radiation Therapy for Osteoarthritis, presented by Dr. Edward Soffen from Astera Cancer Care right here in East Brunswick. I'm so honored to introduce this program because this is such a state-of-the-art and new, exciting way to treat osteoarthritis. And I'm so honored that the library can be a venue to showcase this new technology. This program is being brought to you by the library's Just for the Health of It Health Literacy Initiative, which is our library's program to educate and empower our residents so everybody has a chance to understand the treatments for their various conditions, understand their conditions, and make the best informed choice to advocate for themselves and for their loved ones. Now, just a little bit about Dr. Soffen. He received his Bachelor of Arts degree in biology, graduating Phi Beta Kappa from Johns Hopkins University in Baltimore before obtaining his medical degree and his selection to Alpha Omega Alpha Society from Temple University School of Medicine in Philadelphia. He completed his residency in radiation oncology at the Hospital of the University of Pennsylvania in Philadelphia. And again, I am so honored to turn the program over to Dr. Soffen, and I thank him for taking his time from his very busy schedule to meet you all tonight. So welcome, Dr. Soffen.
Thanks, everyone, for coming. The last time I gave a talk for the library was on a Zoom, and I felt like I was talking to a screen. I didn't know if anyone was even on the other side of the ether. And so when they asked me if I would talk for the library again, I said, yes, but please, can we have some type of audience? So thank you very much for coming. The first question that you should have is, why is an oncologist, a radiation oncologist, talking to you about osteoarthritis? That's the first question. And I hope in the next 45 minutes, I'm going to answer that question. I've given many talks on cancer in the last 33 years of my career on just about every cancer that you can think of. I'm not going to list them. This is the first talk that I'm giving on a benign condition. So you are the recipients of my first experience giving this type of talk. And it is radiation therapy for osteoarthritis. I can't go into the present and the future without talking a little bit about the history of radiation. You know, my field, radiation therapy, is only 130 years old. It is one of the newest fields. We've had surgery back in the time of the Egyptians. We've had infectious disease in the 16th and 17th century. Internal medicine, gynecology, back into the Stone Ages. But radiation started with William Röntgen, who in 1895 discovered the X-ray. He was playing with the cathode tube, and he noticed he had a photographic plate on the other side of the room on a wall, and he noticed that there were images from the cathode tube projecting onto that photographic film. And he worked on it for several years, and he came up with what we now call an X-ray. You see right here, you see my pointer, that is the first X-ray of a human that he took. And do you know who he took it of? His wife. It's very nice of her to volunteer. That's her, right? Where's that pointer? Here we go. That's her. She got second billing, but he is really the founder of our field. And just let me see, 6 years later, he won the very first Nobel Prize in physics that was ever awarded. I'm getting a little reverb. The next three forefathers of, this right here is Henri Becquerel. He's not well known, he's not well heard of, but he discovered radioactivity. I thought for many years that Marie Curie, who's right over here, that she discovered radioactivity, but she didn't. She and her husband, Pierre And Marie Curie discovered the first two radioactive elements, radium and thorium. Now the pair won the Nobel Prize just several years after Roentgen. Marie Curie was the first woman to win a Nobel Prize, yay. And actually, she's the only woman to win two Nobel Prizes. So a big round of applause for Marie Curie. After the talk, if there's some time, I'll tell you a funny story about my visit to the Curie Institute in France, but it's not related to this topic, but if we have a few minutes. So these are the founders of our field. And, you know, for many years, I would say from the early 1900s to 1920, 1930, we didn't know what to do with radiation. We know that it affected things. It was used for treatment of almost anything you could think of. Tinea, ringworm. This is before we had antibiotics. It was given for abscesses, infectious diseases, acne, all sorts of things. And then there grew a fascination with this radioactivity in terms of cosmetics and things like that. There was a toothpaste that was marketed in Germany. It was called Radiozahn, and it had radium impregnated within the toothpaste because after you brushed your teeth at night and when you smiled, your mouth glowed. And I'm sure many of you have heard about the radium girls. These are women who painted radioactive paint on the watch dials so that the numbers would fluoresce at night. It was a very prestigious job. They got paid very well. They used to take the paintbrushes that had radium in them and lick the fine paintbrushes so that they could paint. They were called artists, but of course, they suffered the consequences of ingesting radium for so long. Again, we didn't know what it was used for. Because radium fluoresced and gave off energy, people thought that it was a good antidote for low energy, even impotence. Anything where your body needed energy, you could drink this radium water. I mean, can you imagine the FDA approving a radioactive material for us to drink? But, you know, as time went on, we really learned the uses of radiation, how it can be focused in a way to be beneficial to people and to not cause long-term issues. And that's what our field has evolved in from the 1950s up into the 21st century. A really focused ability to target certain areas of the body, minimizing dose to surrounding structures. So now we're going to talk about osteoarthritis, getting away from cancer. Actually, I found the article of the first patient who was treated with radiation for osteoarthritis. It was 1898, just 3 years after X-rays were discovered. I mean, we had no idea, but they had this new tool and they wanted to use it. And I don't remember who wrote the paper, but it's been used for over 100 years. Radiation for osteoarthritis did have a swing of importance in this country up until about the 1960s, 1970s. And then when the nonsteroidals were born and pharma pushed these nonsteroidal pharmacologic agents, the use of radiation for osteoarthritis really fell out of favor, but it didn't fall out of favor in Europe. And that's where we have most of our data now coming on osteoarthritis. But it is a big problem in this country. First of all, there are several types of arthritis, arthritides, joint problems. Let me just backtrack. An arthritis is a degradation of cartilage in the joints. In any kind of joint, we have a bone and we have another bone, and they are joined by tendons, and in between is cartilage. And when that cartilage starts to degrade, the bone surface gets rough. That mechanical trauma brings in inflammatory cells, which brings in more inflammatory cells, and those cells degrade the cartilage even more. And as the bone roughens, the outside of the bone, the periosteum, which is highly innervated, becomes painful. So that is what arthritis is. Osteoarthritis is really caused by mechanical trauma, just using your hips and your knees and your hands for decades and decades. It's a mechanical issue. There are other types of arthritis. There's rheumatoid arthritis. There's psoriatic arthritis. We have less data on those type of arthritides, but the most common type of arthritis or joint issue is osteo. It's estimated to affect 32 million Americans at this time. I mean, this is a huge medical problem. It's the second leading cause of disability, and 1 out of 7 Americans will develop osteoarthritis in their lifetime. 1 out of 10 will develop cancer. So it is a bigger problem than that which I've been trained for to treat all my life. Some of the risks for osteoarthritis are age. As we age, and we're all aging, fortunately, the risk of arthritis is greater. Gender. Women have a higher incidence of osteoarthritis than men. I'm not sure why. You can see the distribution. The knee is the most common, hands and hips. Those are the 3 most common joints, probably because those are the joints that we use the most. Body mass index, the heavier you are, the more weight you're putting on your joints, the more trauma you're going to sustain to those areas. And then there are certain genetic factors. If you have a family member, a parent who has osteoarthritis, you're twice as likely to develop it. So there is some type of genetic component to it. How many of you remember Walter Brennan and the Real McCoys? All right, good. Because if I know the people in the back who work with me, they've never heard of him. But, you know, before I went to medical school, I was an actor, not a successful one. And that's why I went to medical school. But I can't get in front of a group of people without doing some type of entertainment. So since you all know Walter Brennan, do you remember the way he walked? Yeah, and he sounded like this. If you remember, gosh darn, if we had that low dose radiation years ago, I'd be walking into the barn. Luke, the barn's on fire. Gosh darn, whippersnapper. All right, you remember who I'm talking about. Anyway, he's the first person I remember as a kid watching him and like, how is he walking like that? He had the worst arthritis. I don't know if he really had it or that was the part that he was playing. He was playing the grandpa and he played it well. He played an old arthritic guy. So I had to throw that in. As I mentioned, arthritis is a major burden in this country. By 2040, 10% of us will have some type of arthritis that limits our activity. Now, with that limitation comes a lot of other things. If you're not active, you're going to be more sedentary. If you're more sedentary, you're going to put on weight. You're going to have cardiovascular disease, heart disease. It's been shown to have a higher incidence of anxiety and depression. Look, I played tennis since I was 10 years old. I mean, that's part of who I am. You know, that's my sport. If I get arthritis in my shoulder and I can't play, that's going to be a part of my life that is gone and I'm going to be depressed. So there are lots of other issues besides the osteoarthritis where this affects health, mental health, other physical health, cardiovascular, and weight. It is the second most costly health condition in the United States. If we look at the cost of hospitalizations, 4% of that cost, this is just inpatient hospitalization, is related to osteoarthritis. There's also financial burden with people who have osteo. Typically, if those people are working, they make $4,000 a year less because they're disabled more. They can't get to work as much, or they can't do as much physical work. And it costs them about $11,000 per year just for x-rays, MRIs, doctor's visits, non-steroidals, injections. So it is a financial burden. The total cost for osteoarthritis in this country, including loss of wages and medical care, is over $80 billion. It's incredible. This is a problem. And now we're going to help. The management of arthritis, I think of as a pyramid that you see here. This was devised by orthopedic surgeons. Of course, they put at the top of the pyramid surgery. But, you know, it starts with sort of the non-pharmacologic techniques, people who have early osteoarthritis. They're going to do physical therapy, maybe some weight loss, some education. They might wear a brace. So all of that is related to decreasing the mechanical trauma, but it doesn't really get rid of the inflammation. Inflammation is there, you got to get rid of it. You can certainly try to prevent it from getting worse by walking differently, by doing physical therapy. The next step on this pyramid are the topical NSAIDs, lidocaine patches. There's capsaicin, which I had to look up because I've never used it, but capsaicin is a cream that's made out of chili peppers. And you put it on the joint and it sort of depolarizes the nerve endings. At first it hurts, but then it sort of depolarizes the nerve. So it really is an analgesic. It gets rid of the pain, but it doesn't get rid of the problem. And you have to keep using it, and ultimately it doesn't work anymore. Then we move up the pyramid to systemic analgesics. I'm going to talk for a second about that. Those are the non-steroidals like ibuprofen, Advil, Motrin. Those are the brand names. Naproxen, Celebrex, meloxicam. How many of you have been on those? Me too. They work for a while. They are anti-inflammatory, but they cause a lot of problems. In fact, when I get a fever and I tell my wife, I say, I'm going to take some Advil. She goes, no, take Tylenol. Why? She goes, you can get a heart problem from the Advil. You have to take ibuprofen over and over again in large doses for long periods of time, but there is a higher risk of cardiovascular events in people who take non-steroidals long-term. There's 7 in 1,000. Oh, I'm sorry. 7 in 1,000 will have a non-fatal cardiovascular event a year, and 2 in 1,000 people will have a fatal cardiovascular event. There's a 4 times increased incidence of GI bleed. I took baby aspirin for a while. I got a duodenal ulcer. I had a GI bleed. So some people are exquisitely sensitive in terms of the toxicities of the non-steroidals. And also, as we age, our kidney function gets worse, and these non-steroidals can affect blood flow to the kidney and can cause kidney function or renal dysfunction to occur. So there are lots of toxicities from these systemic non-steroidals. When they stop working, or if a patient can't take them anymore because of the side effects, a lot of the surgeons will start doing interarticular steroid injections. How many have had injections in their back or their hips or their wrist? That's the next step along the line. And finally, when you have bone on bone and nothing's going to work, even radiation, then you have a joint replacement. So the question is, where in this pyramid should radiation come in? And my feeling in the 6 or 7 months that I've been doing this is it needs to come down lower in this pyramid than when you have advanced disease. And the people who we've treated, I have found that the earlier in the course, as long as they have some joint space, as long as they have some cartilage, they're probably much more likely to have a benefit to this low dose radiation than if they have bone on bone. I'm going to talk for 1 minute on radiobiology, because that is a good way to put everyone to sleep. So it's one and only one slide. When we give radiation, we give a chunk of radiation. We know how much dose we want to give someone. If it's a certain type of tumor, it needs this dose. If it's a certain type of tumor, it needs this. If it's arthritis, it needs that. But we call the amount that we give each day, because we usually give radiation over several days or several weeks or even several months sometimes. What we give each day is called the fraction size. So I want you to be familiar with that term because it's hard for me to not talk about fraction size. In doses where we give 100 rad a day, I'm going to use that term, a rad. It stands for radiation absorbed dose. There are lots of other terms for it, but I grew up in the old ages and we call them rads. So if you give more than 100 rad per day, you tend to cause cell death, which we like when we're killing cancer cells. It can cause scar tissue and it can cause inflammation. If we give less than 10 rad a day, that actually seems to be also pro-inflammatory. So there's that sweet spot between 10 and 100 rad where we actually have an anti-inflammatory effect. So it took a number of years to find out not only what dose do we need to give, but how much, what is the fraction size that we should give. And I want you to remember that 50 rad really ends up data-wise and theoretically to be the sweet spot in terms of the fraction size each day, 50 rad. And that'll be important when I look at some of the studies. All right. This is a complicated slide. I like to put in one complicated, pretty picture. I can't even read it, but what it is going to remind me to do is to tell you the 3 ways that radiation affects inflammation. So if you remember nothing more, these are the high-level important points. Okay. We know that when we give ionizing radiation, we cause holes and nicks in tumor DNA. When a tumor cell tries to divide, if the DNA has been irradiated, it cannot divide. It goes through something called apoptosis, which is a programmed cell death. So I can irradiate that cancer cell. It lives until it tries to divide. All cancer cells try to divide, and then it implodes. So cancer cells die a mitotic death, and that can occur weeks and months after they're irradiated. That's why some tumors disappear slowly. Lymphocytes, which are the culprit in this joint space, die immediately. They don't even have to go through a cell division. We don't know why, but they die what we call an interphase death. As soon as you irradiate a white blood cell, a lymphocyte, it lyses. So we very quickly, when we treat a joint, we very quickly eliminate the lymphocytes that are in that joint space. Okay, but what prevents more inflammation from coming in? 2 other mechanisms. There are macrophages. A macrophage is another type of white blood cell, but those macrophages secrete something called a cytokine. It's a small little protein, and a lymphokine. These are little proteins that tell the white blood cells in the rest of the body, hey, come here, we have a problem. It's like if we have an infection and there's bacteria, the macrophages get to that area, and then they recruit all the other white blood cells to come and attack the bacteria. Those are cytokines and lymphokines. Macrophages secrete these, which call more inflammation into the joint. Is everyone following me? Okay. This low dose of radiation, the 50 rads a day, changes the phenotype of that macrophage. So it no longer secretes, it stops making cytokines and it stops secreting them. So it changes the whole existence, the reason for it to exist. It no longer is recruiting, it stops recruiting lymphocytes. So that's the second mechanism. And the third mechanism, you can see up here, this is the blood. This is the arteriole, the blood vessel, through which the lymphocytes are now coming into the joint space. Those blood vessels are lined by these little cells called endothelial cells. And the lymphocytes can get through very easily because those endothelial cells aren't really tight to each other. They're leaky. We want them to be leaky because we want white blood cells to be able to come out of the blood vessels and destroy whatever needs to be destroyed, unless it's our cartilage. This low dose of radiation causes those endothelial cells to stick together. So those lymphocytes can't get back into the joint. So it's a 3-mechanism approach that this low dose radiation does. It kills the lymphocytes immediately. It changes the phenotype of the macrophage, and it makes the endothelial cells less permeable to more inflammatory cells coming in. How's that? That's what that slide is about. So, you know, we have been using radiation for benign conditions a lot in the United States. We use it for meningiomas, schwannomas, paragangliomas. Hidradenitis suppurativa is a condition where our sweat glands are overexuberant, and radiation works very well for that. But these are all anti-proliferative conditions where we use high dose per fraction, doses per day that are more than 100 rad. We have not used in this country low doses of radiation for a number of years, and I'll tell you why. But in Germany, 1/3 of all radiation patients are being treated for benign disease. So why is Germany and Central Europe different from the United States? They treat over 15,000 osteoarthritis patients a year in Germany alone. Well, I found out that there are three major reasons why it has not caught on in the United States. The biggest one is referral patterns. Orthopedic surgeons love to see their patients over and over again. And I think if they knew about radiation, they might be reluctant to send their patients to us because then they're no longer their patients. Rheumatologists, physical therapists, they like the patients come back and back and back. That's probably one of the reasons. Or they just don't know that low-dose radiation can treat arthritis, bursitis, tendinitis, all of the itides, all the inflammatory conditions of the musculoskeletal system. But one of the concerns that I think caused a fall in favor in the 80s and 90s was the risk of secondary malignant tumors. We know that low doses of radiation can cause cancer. We learned that in 1945 with Hiroshima and Nagasaki. 20 years after, if people were exposed to a lot of radiation, they died. Some people died immediately. Some people died of bone marrow failure in a month. But people who were far enough out were just exposed to very low doses of radiation. And some of those women, particularly teenage girls whose breasts were developing, had a higher incidence of breast cancer. And so we learned about 20 years later in the 1960s that exposure to low doses of radiation can cause cancer. So that suddenly became a concern. This graph here demonstrates that if you get exposure as a youngster, very young age, then your risk of developing a cancer is higher than that of the general population because you have more and more decades at risk. If you're a certain age, like above 40, then if you get exposed to radiation, your risk of developing a cancer in 20 years is actually less than the average population. So we want to limit who we're seeing and who we're treating to people who are very unlikely to develop a skin cancer from this low dose of radiation. And what I tell people is, if I had to quote a number, the best number that I can come up with is about 1 in 3,000 patients who get low dose radiation will develop a skin cancer, like a basal cell, which by the way, you could just take off, in 20 years. That's the latency. We learned that from Hiroshima, from 3 Mile Island, from Chernobyl. It's about a 20-year latency to develop a skin cancer. So, there was a study done in Europe where a large cohort of women were given radiation to their shoulder for arthritis. Their incidence of breast cancer was no higher than a same cohort of women that were age matched who did not have radiation. So there was no higher incidence of breast cancer in women who had radiation right here. And there has not been a single cancer in the literature that has been attributed to low dose radiation for osteoarthritis. We still tell people, yes, it is a theoretical concern. If you're 70 years old, I don't think you have to worry about a radiation-induced malignancy. It is extremely unlikely. Okay, so the Germans came up with 3 levels of recommendation: A, B, and C. A recommendation for plantar fasciitis is this should be given. This works. It works beautifully for plantar fasciitis. I didn't know that until I read this article. I've known people who can't walk for months with plantar fasciitis. The level B recommendations for the knee and for the elbow are radiation should be given, and level C for hip and hand could be given. So the data supporting the efficacy of different joints are not as strong. There's very little data on the ankle, and that's why they don't have any level of recommendation. But for almost every other joint, there is could, should, and definitely should treat. And that's the German recommendations. Now, you'll notice that no one has put spine arthritis up on here. Anyone know why? My thoughts, and we've talked to the author of the article from Germany. He did a little webinar for us. When we treat the spine, you know, x-rays go in one side and out the other part of the body. When we're treating a shoulder, the only thing we're treating is skin, muscle, and bone. When we're treating the knee, we're treating skin, muscle, tendon, and bone. The bone and the muscle and the tendon are what we want to treat. So there's no organ that gets in the way. When we treat the spine and the x-rays come into the spine, they're going to exit through the intestine, through the stomach, through the kidneys, the liver, all the abdominal organs. And that does raise our antenna. So what's our solution? How many of you have heard of our proton center? About 10 miles from here. A couple of people have heard of. So a proton is a type of radiation, which is a particle. Unlike the X-ray, which goes in one side and out the other, the particle, the proton, goes in a certain distance and stops. And I've described it as like throwing a dart in the wall. When the dart hits the wall, it stops and it gives off all of its energy. So we can layer the protons into the spine and have them stop in the joint, and they don't exit through the rest of the body. So because there are only 30 proton centers in the country, no one has started to do proton beam irradiation for spinal arthritis except us down the street in Somerset. So we just treated our second patient with osteoarthritis of the spine. So we're using x-rays for all the other joints. For the spine, we're using protons. Now, as I said, this is new in the United States for reasons that I told you. It is not new in Europe. 4,000 patients have been written up in retrospective studies, 1,100 patients in prospective cohorts. And the response rates are phenomenal. Anywhere from 60 to 90% have improvement in pain, in mobility, and in function. There's no evidence of negative effects on the normal tissue. It does not preclude you from having surgery if you ultimately need a joint replaced. It does not in any way impact the surgeon's ability to do the operation safely. And many patients see a response even by the end of their treatment. The majority of those who do respond have a long-lasting response. Now, I've only been doing this for 6 or 7 months. I don't know how long our data is going to be valid. When we asked the author in Germany, how durable his response was, he said, "It is very durable." So it is very durable. So I can't tell you that it's durable for 5 years or 10 years, but I know that for as long as we've been doing it, it does seem to have a prolonged response. And the good news is we can do it again, and we can do it again. The most that people have given in the literature is 3 courses of radiation. Doesn't mean that we can't do more, but you know, most people respond by 1 course of radiation. I'll tell you what that is in a second. For the 20 or 30% who don't respond in the first, we give a second, we have close to a 90% response rate. The next 3 slides, I'm just going to zip through, but this is proof that there are many studies that have been authored and published on this. This is not a new concept. It's just new in the United States. And if we look down the response rates, they range from 60 to 90%, just like what was written. The last 2 studies, which are here, these 2, are prospective randomized studies. Those aren't retrospective. So in our field of medicine, we think that the gold standard is a prospective randomized study where you treat half like this and half get placebo. And then you can really see whether it works. Well, these 2 studies randomized people, I think it was to the knee, Yeah, knee in the hand. One study was knee and one study was hand. And half the people got radiation and half the people got sham radiation. That means they actually went into the room, they made a noise so that they didn't know if the machine was on or not, but they didn't get any radiation. And you know what? The response rates were the same. There was no difference in pain relief, but pain relief was quite low. It was 44% and 29%. That's much lower than the other literature. So a lot of people in this country, they say, well, you know, the two gold standard studies, the randomized studies, that's where we hang our hat. Didn't show a benefit. So how do I acknowledge that study and still want to give this treatment? Well, we have to find criticisms of that study, and there are many. First of all, in each study, there was about 50 patients. That means you have 25 patients in each arm. Just 2 or 3 people who respond or don't respond is going to skew your data. When you have large numbers of patients in a trial, then a small number that go one way or the other or don't report well or don't follow up is not going to skew the data. So the first thing is there were very low numbers in these studies. They had very short follow-up, 3 months. If you didn't respond by 3 months, you were considered a non-responder. We know that 20 or 30% will respond with the second course of treatment. And they did not allow a second course of treatment in those 2 randomized studies. 50% of the patients in those studies had pain for over 5 years. That tells me they had advanced osteoarthritis. They were right up on that pyramid needing surgery. They had bone on bone. And I know from our experience, if you have bone on bone, it may help, but you're less likely to enjoy the benefits if you have really advanced arthritis. And half the patients in that study had advanced arthritis. So I wouldn't expect radiation to work for them. And finally, I'm going to ask you to remember back to the radiobiology lesson that I gave you. The dose that they gave each day, the fraction was 100 rad. So they were giving a pro-inflammatory dose and didn't get a response. So, I mean, why they didn't use 50 rad as their fraction, I don't know. But that's the study that ought to be done. 50 rad times 6 compared to no radiation. Any kind of placebo is going to work 20 to 30% of the time. But this works 80 to 90% of the time, particularly if we give a second course. So my criticism of those studies that people have hung their hat on is the studies were horrible. They made no biologic sense. So what's our criteria for treatment? I want to treat people who are above age 40 only because of the theoretical risk of a longer exposure and the potential risk for secondary cancers. We like that patients have documented arthritis. We want to see an X-ray or an MRI. If someone comes to me and says, I have arthritis in my knee, well, I have to see some radiographic proof of that. And also, they should have failed some type of treatment. If they haven't done physical therapy or tried a non-steroidal, then, you know, let's give that a try first before we jump to radiation. But I don't want to get the patient when they have bone on bone, when they cannot tolerate their non-steroidals anymore. Contraindication, obviously, we don't want to treat a pregnant woman. We don't want X-rays anywhere near there. And if they have acute connective tissue disorders like lupus or scleroderma, even very low doses of radiation can cause scar tissue. We don't want to cause scar tissue in the joint. This is sort of an example of the fields that we set up. I'm going to focus on the knee right here. So we don't just treat the joint space, which is right here at the center of the field. You see this line? That point right there is called the isocenter. You don't have to know that, but people in the back are very familiar with that. By the way, 4 of my fantastic therapists from Monroe are sitting in the back seat. So you may get to know them, not because of cancer, but because, and Jan, who is our office, everybody, but they will take excellent care of you if you come for low dose radiation for your osteo. But anyway, I don't want to treat just the joint space. I want to treat the tendon insertions. I want to treat the bursa in case there's a bursitis. And so the fields look more like 7 or 8 inches or, 10, 12 centimeters, because I do want to get the joint, the tendon insertions. This is an example of the hip treatment. Now, what we do is we do throw in shields that block out some of the soft tissue. We don't see these in these images. This is an SI joint, sacroiliac joint, ankle. This didn't show up well. This is an elbow. This works great for elbow arthritis and tennis elbow. And we don't see here the shoulder well. That was my fault. I didn't lay it in right. But the dose that we use in our practice is 50 rad. Remember, that's the sweet spot. And we give 6 treatments. We give 6 treatments every other day, Monday, Wednesday, Friday, Monday, Wednesday, Friday, or we'll do Tuesday, Thursday, Tuesday, Thursday, Tuesday, Thursday. So it's 3 times a week for 2 weeks or 2 times a week for 3 weeks. And that seems to have the greatest benefit with virtually no side effects. How many of you remember Usain Bolt? Remember the Jamaican sprinter, the fastest man in the world, won 3 gold medals. Well, between his second and third gold medal, he went to Germany because he had tendonitis in his leg. He couldn't run. He got his 6 treatments, 50 rad times 6, 2 weeks, and then he won his 3rd gold medal. So it works for tendonitis. And there's a video of him that you can find on YouTube. So our experience, I read this article, this great review article about 9 months ago. And I'm like, why are we not doing this? It seems to be very efficacious. I asked Jan, raise your hand. I said, Jan, can we do this? And she said, I don't know, let's try. Let's see if insurance pays for it. That's a big thing. Let's see if it works. So we started a study of about 10 patients. And I said, come to our office, because if it's not paid for, we'll just forget it. But we want to see if insurance pays for it. Guess what? Insurance covers this. It's FDA approved and insurance covers it. So the people who were our first volunteers were people who work for us because they aren't afraid of radiation. They work around it every day. Wendy, raise your hand. She was the second patient I treated. She could hardly walk, her knee, and now you'll see her dancing out of here. We asked people to fill out a WOMAC form. It stands for Western Ontario McMaster University's Arthritis Index, WOMAC. I never remember that. But we have them fill it out when they come in for their initial treatment. We have them fill it out a month after when they finish, and then a month later when we see them. So we can actually quantitate how their WOMAC scores decrease. They have less pain, they have more mobility, they have more function. And you can see in the patients who I've treated, about 80% have a pain response that's improved, 85% response in stiffness, and 90% response in physical function. So this is better than placebo. And the good news is there's like no side effects to it. People just tolerate it without any skin redness, without any fatigue, and then they can start using their joint again. So conclusions, I guess I have several of them. This is a new old concept. It's new now in the United States, and people are starting to think about using it, but it was used over 100 years ago when we didn't know really why it worked. And it's going to help a significant number of people. This is a major health problem. It's highly effective. There are no side effects. It can be repeated. If the pain improvement is not 100%, we can always give a second course and even a third course. The later that it's incorporated into the disease process, when you have bone on bone, we'll still try it, but it's probably not going to push off the surgery that you're going to need. It's covered by insurance. Someone asked me that question. They said, I have 2 questions. Can you use it on the hip? Yes. Does it work? And does insurance cover it? Yes. And here's the number that I want you to call. I want you to call that number, 609-655-5755. It's on that form. That's where we have the greatest experience doing this. That's where we're studying it. By studying, that's where we actually take your WOMAC score. And any one of us who practice that office will be happy to see you. We do ask that you have or bring with you your x-rays or your MRIs. We have to see something that documents that you have arthritis. And if you come without an X-ray, we're going to send you next door to get one. It's 6 treatments, as I mentioned, Monday, Wednesday, Friday for 2 weeks, or Tuesday, Thursday for 3 weeks. It takes about 5 to 10 minutes a day. And hopefully you'll be playing tennis and golfing and not sitting around in those decades where we have the time to enjoy physical activity. And that's it. I'm up for questions. So the question is, would I still recommend it for knee osteoarthritis if the cortisone injections and the gel are still working? It won't hurt to do it now. Once the gel and the steroids stop working, that's when you have a more significant problem. And the two can complement each other very well. I would not do the radiation shortly after you had the steroid injection. I would wait until it had sort of tapered out and then do the treatment. So I think it's more, if your pain is good, is well controlled, it might be reasonable to do it prophylactically, and then you might not need the steroid injections, which actually can introduce bacteria. I mean, there's potential toxicities from the steroid injections in the gel, but it would not preclude us doing it at this point. Yes. So the question is, she's had lots of radiation for different cancers or different cancer sites and has osteoporosis. This will not help osteoporosis, but if you had osteoarthritis in an area that had not received a lot of radiation, if you had breast cancer and part of the shoulder is usually blocked when we treat, but if you had a bone metastasis, we probably would not retreat that area. But if an area of your body had not received radiation, there's absolutely no reason why you couldn't have it. If you come from a family with melanoma, I would just say it is still very unlikely that the radiation will induce a melanoma. It's going to take 20 years, but I would add that into the discussion. It would not stop me from offering it to you. I would pause for 1 second to say, look, we have to be diligent about skin checks. And that's not just to the area that we treated, but you need your whole body checked once or twice a year by a good dermatologist. Okay. I just want to go over to you. Absolutely. Stimulate. The only thing we do worry about a little bit is a pacemaker. If the pacemaker is in the field, we actually just recently started treating a woman. We're treating her shoulder. Her pacemaker is right up here. So we angled the beam away from the pacemaker, but a stimulator wouldn't bother it. Let me go to you. The metal would not perturb the radiation. I haven't treated someone who has metal in the joint or across the joint. I have to think about that. Okay. I mean, listen, I'm 6 months into it. I have more experience than most people in the country, but it's only 6 months, 40, 50 patients. So I have to think about that one a little bit. Okay. Let me go to you. You know, the ankle, it's a tough one. It's a tough joint because, first of all, there are about 8 bones down at the ankle. And it's hard to know exactly which bones are the ones that are painful. It's usually the calcaneus, which is sort of our heel, and where it attaches to the tibia and fibula. That joint gets the most pressure of any joint every time we walk. We put pressure on our heel. So the data is less impressive because a lot of people just don't treat the heel. But you know, for tendinitis, like Achilles tendinitis, I would certainly offer it. I would have less of an expectation that it's going to be beneficial because the trauma is constant and it's there every time you walk. And that's why there isn't a strong recommendation for ankle osteoarthritis. But if it's a calcaneus tendinitis, it works beautifully. So it works very well on the tendon, not so much on the bone because of the constant trauma. We have radiation therapists. They're all board certified. Would you 4 stand up? These ladies are awesome. I would trust my family. I would trust myself. When I get arthritis in my shoulder, I'm going to them. So I do all the planning. Our physicists and dosimetrists help do all the calculations. Those ladies will set you up each day and treat you. No. If you can drive yourself, yeah, you drive yourself home. No nausea, no vomiting, no hair loss. This is, oh yeah, yeah. You had a question. Yeah. Okay. Oh, we're going to do some chat questions. Okay. Well, let me do hers first. So the question is, if you have multiple joints like in your hands, like the distal phalangeal, the proximal phalangeal joints, the carpals, we can treat all of them at once. I do avoid the nail bed because I don't want your nails to fall out. And we can even treat both hands at the same time. This should not affect immunosuppression issues at all. Not at all. Wait, we're going to do a question. Well, this is not my area of expertise. That's an orthopedic question. Is what about PRP? That's the peripheral plasma that they inject in the gel. I think they are of questionable efficacy. My orthopedic friends tell me that they work about 30% of the time. It's not covered by insurance. It costs thousands of dollars, and it's of questionable efficacy. I'm not against it. I'm sort of all for throwing the kitchen sink at these osteoarthritic joints. But beyond that, I just don't know that much about those peripheral plasma injections. That's a good question. I think people, after they have the treatment and they suddenly have use of this joint that they favored for many years, they overuse it. And I think now we recommend, after we treat someone, that they get physical therapy for several weeks so that they can relearn how to use that joint so that they don't stress the muscles, that they don't get a myositis. And so, yeah, I think overuse, because they are now pain-free, is a particular problem for it not working. Let me go up. You've had 2 treatments for with radiation, and you're already playing pickleball. Well, stay out of the kitchen. Yeah, that's great. So they are. I know. No restrictions, but don't overuse it either. We'll do two body parts if they're on the same side of your diaphragm. So we don't have to flip your position on the table. I usually like to take the area that's hurting you the most. And if it's the shoulder, we'll do both shoulders. And we've sort of worked around the body in, going from the most painful to other areas, but we like to limit it to 2 sites at a time. But that doesn't mean, like, if you have multiple issues in your hand, that's 1 site. A long time. That's all I can tell you. I mean, so far 2 or 3 of our 40 patients have needed a second course, and it's worked, right, Wendy? Second course, it worked. And I think Wendy used her knee a little too much. She's getting people on the table all day long. But listen, I don't have a good handle on how durable it is. If it's 1 year, 5 years, 10 years, so far it's been very durable and very complete. Is there another? I've never heard of laser therapy for a joint issue, so I can't answer that. I don't know. I've never heard of laser therapy in the joint. Has anyone? One second, back there. How do we determine if someone's a candidate for well, I look at the x-ray. I do a physical exam to feel the joints. And if I'm convinced that the patient has osteoarthritis and they meet all the other criteria, they're over 40, they've tried nonsteroidals or physical therapy, and it hasn't worked. Sure, why not? There's no downside to it. If there was a lot of toxicity, I would have a much higher threshold to recommend it, but there's virtually no toxicity to this. So you had to go. The question was, why would you negate? I mean, if someone has bone on bone, why would you not offer them treatment if you're also treating some of the tendons and the bursa? I mean, the problem is we don't know when someone has arthritic knee, for example, if it's from bone on bone, the pain, if it's from a bursitis, it's from a tendinitis, because sometimes you get a tendinitis because you are favoring that joint. And so I want to treat the whole area to get whatever inflammatory process is going on. But if it's bone on bone that's causing the pain, we're just not as successful because no, I mean, I've treated people with bone on bone and they've gotten better, but I can't say our response rate is 80 to 90%. There's one man, we treated his shoulder twice and he has no pain improvement and he has bone on bone. Now he's one patient. We've treated at least 5 or 10 people who have bone on bone and they had improvement, but I'm not as enthusiastic where I'm going to say there's a high likelihood you're going to feel better and it's going to be durable if it's a bone on bone hip or bone on bone shoulder. Back to you. That is a great question. I'm sort of still grappling with that. I treated someone with rheumatoid arthritis. Rheumatoid arthritis is an immune complex deposition in the joint. So it's the immune complexes that cause the inflammation. It's not necessarily mechanical trauma. Now, this woman does sign language for a living and her joints, she couldn't work anymore. I treated her. On the last day I went in to see how she was doing. She signed to me. So it does seem to have some efficacy for rheumatoid arthritis. We have not treated anyone with psoriatic arthritis. You know, the mechanism of that is a little bit different than immune complex or just mechanical trauma. So I have to punt on that question because I have to think about that and maybe do a little research. Well, it depends what's causing that bone edema. Inflammation causes edema. If that's the reason and there's not some other structural thing there, sometimes you have an osteophyte, sometimes you can have a bone island causing edema. If it's inflammation that's causing that edema, then it should work. It's very potent anti-inflammatory that's highly focused. I'm just thrilled that you guys have so many questions, but you already asked one and you already asked one and you did not. Yeah, the hip and the knee we would do in the same day. I'd probably do no more than 5. So like L1 to L5, I might do T5 to T10. I've treated the whole cervical spine in someone. The cervical spine we can treat with x-rays. We don't need protons for the cervical spine. But for the thoracic spine, where we have the heart and the lung, the lumbar spine, where we have all the abdominal and pelvic viscera, I would use protons. Yeah. You know, that's a little bit like that capsaicin. It's a depolarizer, but it permanently denervates the nerve. It's not going to get rid of the inflammation. It's going to get rid of the perception of pain. You may use the knee more if it's painless, and you're going to ultimately probably need a knee replacement because you're not getting rid of the inflammation in the joint. You're just masking the pain. It's like taking a Percocet. All right, we're good. Right on time. Thank you all, and I appreciate it. And I appreciate the applause because I don't hear them that often. And I want to thank our staff because you guys are awesome.
Thank you, Dr. Soffen. I just want to make a quick correction. The doctor's office is actually located in Monroe. I have flyers. He is with Astera Princeton Radiation Oncology in Monroe. So please stop by and pick up a flyer with the contact information.